Thank you very much, Ben, and thank you for the invitation from the people who organised the committee. I'm always amazed that people ask me to talk about this because the news I've got is awful. And it isn't just about other people, it's actually about all of us. So the fact you're prepared to sit through this is quite impressive. I went to see Leonard Cohen recently on his last visit, and he and his musical director were in a cafe, and the musical director this was in Sydney, the musical director was saying, I can't believe why everybody's so cheerful in Sydney. They're all going around looking very happy. Have they not heard the bad news? And Leonard Cohen said, that's why we're here. So the reason I'm here is to give you the bad news, and in a sense, I've already done it. In fact, Michael and I already have, because we're two doctors opening a conference session about end of life. If this was 50 years ago, we would have been priests. What's happened is that death has become a medical issue, where once it was a social, religious, spiritual, all sorts of issues, legal issue, but never particularly medical. And one of the reflections that I made in my abstract was that when I was a kid, death hadn't changed much since when Munch painted this painting in 1895. I knew there was a death in the family as a kid, because I'd be taken to some house with some elderly relative, and the gas fire would be going in the bedroom. Now, we were from a very poor background, so to have the gas fire going in the bedroom, Charlie knows, meant something very bad was going on, and as a kid, this was the only signal I had that this was a death that had taken place. And the first death in the family that I can remember being in hospital, I was already a doctor. So the pace of change of this has been absolutely dramatic in my own lifetime. And this is something that I reflect on when I talk to an audience. In a single generation, we've had to cope with a change in the way that we die that we're decades away from being able to catch up with. So my general principle is that an ethical change, or a medical change, takes about 20 years for ethicists to start pondering what difference this all makes, but we have no rituals to talk about the way we currently die. And while this may look like a rather shocking version of the way we die, I do want to tell you that as we stand here right now, 3 out of 5 people in Miami will die exactly like this. This is not like rare, this is now 3 out of 5 people in Miami. It's not reached that situation in Australia. But the medicalisation of dying has taken it beyond just being in hospital through to being potentially in an intensive care unit. And they don't just turn on the gas fire in the intensive care unit. We seem to have quite a lot of other toys as well. Now, we can speculate on what the drivers of this change have been, and I do think it's speculation because I don't know exactly which of these are important. The demographic shift of the age at which we come to die in first world Australia, and I do want to say in the acknowledgement of the Aboriginal elders that I am talking here about a first world problem and primarily about white Australians, and I think there's a separate talk to be had about Aboriginal Australians. Nevertheless, there's this demographic shift towards dying at a very old age. You could say that materialism is important, the language of rights and the rise of autonomy, certainly medical technology. I think you could talk about a denial of death, but I think it might be fairer to call it an unawareness of death, and I'll show you why that might have arisen in Australia. And of course, because in any audience this size there'll be conspiracy theorists, clearly there's a conspiracy. In fact, there is a bit of a conspiracy, so I'm not going to dismiss that concept entirely. This is a very interesting paper which I really recommend, and Jane Weeks I recommend as an author. She's an oncologist from the Dana-Farber Institute in New York. And she has been asking patients about their expectations of cure, and these are people with metastatic cancer who will not be cured. They have almost a 0% chance of being cured, but 70 to 80% were expecting a cure from chemotherapy. And the most popular oncologists were the ones who fostered that false belief. So it's not a conspiracy, but there is a collusion. And I work in a cancer hospital at the moment, and this collusion is there all the time. And this may be something that we could address systematically. A lot of the things we can't, though, because whatever these drivers are, I think the most important take-home is that they're not reversible drivers on the whole. These are things, the cat is out of the bag, the genie's out of the bottle. I think somebody used this expression yesterday. The genie's out of the bottle, you can't put it back. So we have to deal with the fact that things have changed. And everything has changed. you'll understand that if when we die changes, then there's a flow on. What we die of changes, where we die and how we die. So just a little bit of showing off for the international audience. This is Australian data about preventable deaths. That's the 35 to 69 year age group. These deaths are considered preventable, and we are world leaders in Australia in preventing preventable death. There is no country on earth more successful in preventing dying prematurely than Australia. And this is even the Nordic countries are not better than us at this. So we have done a fabulous job among white Australians at achieving this. But of course the impact of that is clear, which is now that over 90% of white Australians live to be old. And therefore, there you start the flow-on that I'm talking about. Now, if you come to die in your 90s, you're going to die in a very different way than you would have done if you died of pneumonia at 45. There's clearly going to be very different. So to go back to that, when we die has changed, so what we die of has changed, so where we die has changed, and how we die has changed, and this is what we die of. And you'll all be aware, when you look at the websites currently, it looks as though things haven't changed much, and the big two remain the big two, which of course is vascular disease and cancer. But if you actually look at the fast movers, you can see it's a slightly different picture, which is that there's a rapid rise of dementia as a cause of death, and a rapid rise of diabetes, and of falls, which is very interesting too, because this is again a demographic shift. If falls become a common cause of death, it's not young people falling that we're talking about. So in this sort of standardized cartoon of how people die, what you're seeing is very clear-cut, which is a shift from the top left-hand corner to the bottom right-hand corner in terms of the trajectory of dying. So sudden death, I mean, you could characterize that as trauma, but actually more commonly that would have been pneumonia. Terminal illness is commonly a cancer death, but you'll understand that when you're over 80, cancer dying, you may die with but not of cancer, and that more commonly what you're going to see is the relapsing organ failures, which often result in repeated admissions to hospital. Or more commonly yet, and this, again, I'm brutal, I have to apply this to the current audience, for the vast majority of people here, it will be increasing frailty which accounts for you and me in the end. And that there is a massive disability gap in all the OECD countries. Wherever we have prolonged life, we have not closed the gap so that it's not prolonged healthy life. It is on the whole prolonged dependent life. And some OECD countries, that gap's actually widened, not narrowed. So if you actually look at that bottom right-hand corner, the last 2 years of your life are commonly lived with core disability, that is to say, a disability that mandates that somebody else helps you with your activities of daily living. So we're looking at highly dependent people, and this is, of course, impacting on intensive care, and you're going to see how that's impacting on what we do in just a moment. I haven't got comparable data from Australia, but I don't doubt that it's exactly the same in Canada, Australia, New Zealand, that the place of death has shifted. This is Irish data. But as I commented, when I was a kid, dominantly people died at home, and that was obviously true in Ireland as well. But now, as we come to the 21st century, it's quite clear that acute care is now the dominant place of dying, and we've done a lot of work in our own area health service, and it's 67% of people dying in acute care facilities, and that leaves aside private hospitals, which also have quite a few people dying. And there's been a big shift towards cancer patients dying in acute care private hospitals as well, so the picture might be even more so than it looks. And this was a piece of work from Western Australia which we found surprising, so we reproduced this in our own area health service, but that a dying person, if you took 1,000 people who died, which is what they did, and went back over their records and saw what had happened to them in the year that led up to that, they were bouncing in and out of hospital pretty continuously in that time, and that they were coming in through the emergency department and had a very high chance of dying in hospital. And these were all people who were eligible for palliative care, so this was done by palliative care people, David Currow. So we produced this, we didn't believe it, but in fact we got almost identical results from our own area, so I'd be surprised around Australia if there's any real difference. And the drift that I was mentioning before towards dying intensive care has become very obvious on our campus. It's a 1,000-bed campus. And 1 in 4 of the deaths that occur on there occur in intensive care. And importantly, 1 in 4 of the remaining deaths is supervised by intensive care at an outreach, which is rapid response teams that I'm sure all of you are aware of. So that actually takes us up to 50% of deaths on our campus being either directly in intensive care or managed by the intensive care specialists. This is an enormous challenge for all of us, as you can imagine. And within intensive care, things continue to evolve. So this is a nascent specialty. I started intensive care in 1978, but those were the very earliest days of it. I was there for the opening of several intensive care units. But even during that time, we're seeing a massive shift. And these are just some facts and figures that just rub that point home a little bit. So the modal age of admission to intensive care unit in our intensive care unit has gone up by a decade in the 20 years that unit's been open. So it used to be late 60s, now it's late 70s as the modal age, and there's data from Victoria showing something very similar. The data from the Australasian database shows a tripling of discharges to residential care from intensive care. So the survival for sepsis in ICUs is very high and in fact rising, but the discharge destination of the people who survive the sepsis is increasingly becoming residential aged care and not home. And this might turn out to be a very significant factor in many people's decision making, but it hasn't been in ours to this point. An extension of life is often brief now for ICU admissions. So again, data from this same database, we keep very reliable data on ICUs in Australasia, shows that if you're over 80 and ventilated in an ICU, the chance of you being alive in 2 years is negligible. That is to say, it's certainly less than 1 in 5, and most of those deaths occur quite quickly after you leave the ICU. So we have still a high success. People come in, they survive, they go from the unit. They sometimes go from the hospital, but they frequently don't go home. And the real driver of this actually isn't age. Let's just not get ageist about this, because it isn't age, it's actually frailty. And calling a spade, the real reason why we have this problem is that people have accumulated insults over their lifetimes that render them frail. You couldn't characterize any one individual thing, but a lot of it is loss of skeletal muscle, and that's a big feature of frailty. And if you wanted to know one thing about somebody, you'd know how much skeletal muscle have they got, which puts me in a very bad situation, unfortunately. So there's an increasing mortality and length of stay. This is actually Canadian data from Sean Bagshaw, but I'm sure the same applies here. Increasing mortality and length of stay with frailty, increased readmissions with frailty, and this is the italicized bit, reduced by 2/3 the likelihood of living independently once you'd left the intensive care unit. Oftentimes then this starts driving people towards the notion that our treatment may be futile, and this is one of many words that I think we're going to hear a lot over the next couple of days, and I hope we do, because I actually feel like while we've tried to dodge the question of futility, we can't afford to. In fact, in New South Wales health documents, we're tending not to put the word futility in there just because we're so scared of it, but I think we have to reinvigorate this term. Certainly health law has never dropped it, but ethics tried to, unsuccessfully, I think. But nevertheless, they certainly in this particular unit, they felt that maybe as many as 1 in 5 of their patients was receiving treatment that was futile. What was interesting was what that really meant, and this is the table, but you can't read it, so I've transcribed it on the right there. But these were 123 patients they thought were absolutely futile in the intensive care unit, but only 2/3 of them died in hospital, so you could say that that was an inaccurate estimate. In other words, that 2/3 of them actually survived to leave hospital. But actually, when you looked beyond that, 20% more had died in the few months after leaving hospital. 10 were in long-term hospital care, 4 had gone to nursing homes, 2 were still in hospital, and 3 were being palliated at home. And that was the whole sum total. So when we talk of futility, it isn't a question of who survives. It's a question of also how they survive and where they go to when they survive. And this is something we don't currently disclose to people. We talk about life and death. ICU is very much about that. But there's more to it than that. And I think this is what puts us in an extremely difficult situation. We now have to take into account outcomes other than life and death, and we don't know how to do it. I won't dwell on cost, because it will frame what I'm saying as being as if it's health economics that's driving what I say. It's not. However, I do have to point out that the cost of dying is enormous, and that where intensive care is involved, it's enormously enormous. So the reason why in New South Wales, this is New South Wales data, the reason why trauma is so expensive is they'll die in intensive care. And the reason why cancer isn't so expensive when you actually die is they tend not to. But the big bulging costs of cancer lead up to dying because it's chemotherapy. But nevertheless, everybody knows the last year of your life is the expensive year. What people are perhaps less aware of, it's actually the final battle. It's actually the last 30 days of your life that are really expensive, and not the last year, not just the last year. In fact, primarily not the last year. Now, set against all of that, of course, T.S. Eliot said it best, as he often did, but not for the good that it will do, but for nothing be left undone on the margin of the impossible. In other words, nobody became famous for saying things were futile. The most famous surgeon in Australia is not the Australian of the Year, and the most famous surgeon in Australia for saying, oh, neurosurgery is futile in many cases. He's famous for doing it regardless of that notion. So we don't want to throw the baby out with the bathwater here. We're not saying that we want to stop trying to save lives that might be very difficult. And in fact, when I gave a talk like this, a surgeon came up to me and said, what's wrong with just going for it? You know, seriously, why can't everybody die having CPR in the end? What's the problem with that? Well, I've said there's a health economic issue at stake. But I think I also have to tell you, and this is further bad news for me and you, since this is where we're all going to die, or at least 2 out of 3 of us, is acute care is not a safe place to die. A published audit from Monash said there'd been no discussion of end of life until the last 24 hours. The wishes were known and followed in less than 1 in 4, unresolved conflict in 1 in 3. I'm sure this data is not unfamiliar to you. And we've just published an audit ourselves where we were looking at the quality of care received on the day of death and discovered that when on the day of death, 1 in 3 people didn't have anything in their notes that even suggested that they were dying. So to all intents and purposes, it appeared like it was an accident. And as I said in my abstract, there is a commentator from England that said death in acute care is akin to an industrial accident, which is actually a little bit the way it feels sometimes. So they were continuing to have their observations done, like pulse, blood pressure, and only 1 in 4 had a palliative care referral, but none of those were in my hospital because we don't have any palliative care service on our 1,000-bed campus. But what was perhaps striking was that many of them were still having their respiratory rate, saturations, and blood pressure measured. Only 1 in 10 was having a pain score done. And when we audited that, half of them died in pain. So we assuming that we can't change the drivers and that we are all going to die in an acute care hospital, we do have to urgently do something about the quality of care that people receive in that context. And of course, this was a very famous comment by Cicely Saunders, whom I met actually when I was a medical student. And she said that how we die remains in the memories of those who live on. And this is visiting itself on people. So we have family members who die badly, and then another family member comes. This is Newcastle for you, because, of course, it's a fairly closed community in many ways. People know it's bad. And, I mean, Rodney's here, and he knows how high the support is for euthanasia in Australia. And I think people have a justified fear of the way that they might die at present. And we have a responsibility not to debate only whether we should legalise euthanasia, but what it is we're doing so badly that makes Australia such a high supporter of euthanasia in the first place. And to me, that's a primary question, and I think that came up last night. So this is the unique role of the intensivist. The unique role of the intensivist is different from the palliative care specialist. We have to be the ones who make the decision about whether or not this patient should receive care. And I felt very alone doing that many times until I saw this in The Guardian, where David Attenborough and Richard Dawkins, I'm sure you'll recognise them both, were asked what's the most difficult ethical dilemma facing science today? Science, this is not just medicine. And the answer was, how far do you go to preserve individual human life? And that's what I'm sat in the corridor trying to work out quite a lot of the time. And data that Ben and Lindy and others have put together suggests that we're doing this every 13 minutes somewhere in Australia. And that certainly feels that way to us. We certainly do this at least 1 to 3 times a day in a bigger ICU at present, and Charlie Cork would testify to that. We've been doing some data about how long this is taking us, and we've published some data suggesting it takes 2 to 5 hours to reach an agreement that we should withdraw treatment. And we're just working on data at the moment suggesting it takes 1 to 3 hours to come to an agreement to withhold treatment. And I can tell you some terrible stories about my last weekend when at 4:30 in the morning I was called in to see a woman who had what's called cardiorenal syndrome. That's to say her heart had packed up so her kidneys wouldn't work, and she was demented, and they were demanding that I dialyse her. And it took me until midday to convince the family that that wasn't a good idea. So that was from 4:30 in the morning till midday. I had to get the resident to do the ward round because I wasn't available. And this is a fairly common experience in ICU. This is what we spend all our day doing. And we're not, I'd like to say we signed up for that, but the truth of the matter is we didn't. It's just the way it's come out. I've tried, as Ben mentioned, I tried to take some leadership in my own state and my own community in attempting to provide some sense of change here. But I encountered a number of problems in trying to provide such leadership, and the first problem I called Newton's third law of motion, which I'm sure I don't need to tell you, which is that every action has an equal and opposite reaction. And I think you probably saw a little bit of that in the debate last night, which is that there are not going to be any easy wins in this area where it's highly contested. And in fact, I can't remember who was commenting this morning before we came in, but at any meeting at end of life, people arrive braced. There's a position that they're going to defend no matter. And I enjoyed last night's debate, but I still felt like we had some very entrenched points of view that are very representative of what's going on out there. There are also genuine ethical conflicts. These are not doctrinal, these are genuine ethical conflicts, and I think Barbara Hayes has done a fabulous job of teasing those out in the no CPR, in the making decisions about CPR field. And then there's the law, and the law. So to explain, the law is what's really there, which is rubbish. I have to tell you that the law in Australia is rubbish, not just in the area of euthanasia, but in guardianship and end of life generally. And in New South Wales in particular, the law is rubbish. And in fact, Ben and I struggle to even understand what the New South Wales law actually says anyway. So there's a problem with the law, but there's also a real problem with the law, as doctors see it, because we invent gaps. We fill the gaps by inventing law that suits our purpose. So, for instance, an ED registrar will say it's mandatory to treat anything treatable regardless of what the patient has said, which is not true. But we invent law to fill in the gaps of the legal knowledge. And Ben and Lindy and others have shown that there's massive gaps. I hope everybody's read their paper from last week. But there are massive gaps in what we understand about the law at end of life. But what we do with that is we fill them in by inventing the law as we go along. I could go on about that, but I've got plenty of examples. And I think this is one that's just something that's worth throwing in, which is that doctors tend to think in very broad brush. So we like to try and think that we've got the solution. And end of life is irreducibly complex. And I think if you think you've got a simple solution, you're almost certainly wrong. In fact, there's a New South Wales health document that calls the problems wicked. Isn't that right, Julie? They're called wicked. There's one document that says these are wicked problems, and I'd never heard that expression before. Have you heard the expression wicked problems? Yeah. Wicked problems. We pointed out one last night, which is this. I don't think euthanasia is one thing. Euthanasia is like a spectrum that goes all the way from involuntary murdering people right through to withdrawing futile treatment at another end of the spectrum, but I don't think you can draw the bright line in there with any certainty, and it's the one point of agreement we got to last night was that you couldn't do that. The implications of that are devastating if you follow them through to a logical conclusion, because if you don't draw some sort of bright line, then what I do every day of the week is possibly unlawful. And if it were, that means I can't do trials of treatment in the expectation that I could stop again, or that we have to invest at least 100% more in intensive care and keep people alive indefinitely until they rot, or whatever intervenes to stop them. Or that we stop admitting people who are remotely dodgy and don't give them a chance because we don't want to find ourselves in a position of having to stop, which could have the unforeseen consequence of offering less care than is currently available. So I think we have to be very careful about the debate last night, lumping together all forms of euthanasia without drawing the bright lines. Futility, autonomy, best interests. All of this is going to get talked about. I'm not going to talk about it today because this is the subject matter of this. But I do want to say, as an intensive care specialist, we're very conscious of all of this debate going on and the legal cases that we can make no sense of, particularly about best interests. From the signals from the UK are almost impossible to follow. Most dangerously of all, lack of imagination. There's no doubt that the problem that we all face is that we lack imagination here. We confuse empathy with compassion. We don't really understand. We don't live in the shoes of the people who are out there dying. We we are hardwired not to do that. It's very difficult to overcome that. And people who try to overcome that with empathy tend to burn out, and we have to learn compassion, but I'll talk about that some other time. So I think we have to stop debating euthanasia and talk about the euthanasia spectrum and where on that bright line. Given that there is no bright line, where is our comfort zone? I would sooner call it that. Futility is real. It's like pornography. You know it when you see it. But that's really as good as it gets at the moment. But I think we have to revive the debate about futility. Certainly in my state, New South Wales, it is the only absolutely safe grounds on which we could stop treating somebody. And if we don't accept futility, we go for what I call the do-everything default, which is a series of technical and medical imperatives that just end up with everybody dying in the intensive care unit, which is clearly unsustainable and inappropriate. Autonomy, etc., the whole notion that we make our own decisions, or that we make a decision about ourselves in advance, or that we delegate somehow that autonomous decision to somebody else to make for us, or the law delegates it to somebody who has no idea on our behalf, and it gets us into the guardianship arrangements, which in Australia make about as much sense as a nursery rhyme. That's a whole issue for us. Best interests, I've said, we've received extremely conflicting ideas, but when is it in your best interest to die? That's a very difficult judgment to make. And whose decision should that be, which is what I'm looking forward to hearing what Jocelyn Downey has to say. And as I say, lack of imagination. So I do want us to finish with some tentative suggestions, which is as best I can do. I came to give you the bad news, but I can't just do that. It starts with us. We've held some forums with the general public in ACT and also in my town, and it seems quite clear that the general public want us, that's to say the medical people, to be the leaders. They are very happy to talk about this. They want us to talk about it with them back. We need some feedback of some meaningful information. It's been very difficult to get good information about death and dying. We need earlier recognition of end of life and dying. We need to focus on the links between what happens in one place, what happens in another, what's said, and then what's done, and then what happens as a result of that. It's the links that will matter. My suggestion is we adopt the term dying safely in an acute care setting. I think good death is actually a bad idea. I think we should have just an idea of patient safety. We provide safety in so many other ways in healthcare. I think this is just something that we should see as being something we should do safe. Ken Hillman from Liverpool Hospital is promoting the use of this term, and I agree with him that it's less dangerous than saying we're trying to provide good deaths for people. Nothing will improve unless everything improves. And as an intensivist, I'm grown up with this chain of survival, which is it's not just somebody doing CPR that keeps you alive, but all the other things that flow from that. And there is clearly if we're going to die safely, there's clearly a chain of things which has to improve. And when I talk of health literacy, I do include us, that's to say healthcare workers, as lacking health literacy about dying as well. And I'm looking forward to hearing what you've got to say. Thank you very much.
Thank you, Ben and Lindy, for the invitation to speak here today. If truth be told and the emails could be made public, in fact, I kind of invited myself, and so I hope that the presentation will justify itself. Thank you to you. I have a very big admiration for your centre and your collaborators, and particularly our friends in Canada at Dalhousie, who are doing terrific work, and I recognise many colleagues here from the end of life, death and dying, academic and clinical fields in the audience today. Welcome to you all. I went for a run in your beautiful botanical gardens this morning, and the interesting thing is, since I turned a certain age, I noticed myself slipping my driving licence into my pocket. And as Adele Hulse, the chair of the board, Sharon Gray in the Age newspaper, is the chair of the board of the Australian Centre for Grief and Bereavement, says anybody's life can change in 30 seconds. She's a Buddhist. And I'm going to start with Winchester, where I lived when I was a resident in Southampton many years ago, with the tomb of Bishop Richard Fox, Chancellor of England and Bishop of Winchester. And what you see here is this cadaveric sculpture in Winchester Cathedral. And it's interesting because Fox died when he was 80, which was a great age for the medieval world. And he spent a lot of time in his chantry chapel preparing for death. And the cadaveric sculpture that you see there on the left is a medieval, nothing in a medieval cathedral is done for nothing, it all has meaning. And what this is basically telling us is this cadaveric appearance, is that in death we're all the same. You can be very important in life, but in death you're all the same. And also that preparation for death is a very important part of the medieval Christian tradition, which was alive and well in early colonial Australia, as the work of Pat Jaland, the Canberra-based ANU historian, has shown us. And when I showed this slide to a colleague in Hobart who'd been travelling around the world in the 80s, she said, I've got a cadaveric Buddha for you from 16th century Pakistan, where again the message there is live each day as if it were your last, and that's one of the key spiritual disciplines of Tibetan Buddhism. And this is in our unit in Hobart. This I had the permission of the late Martin Heath, a man 72 years old when he died, a relatively short illness with mesothelioma, an industrially acquired cancer of an exposure some 20 years ago. And I was talking to him about this invitation to speak. And he said, I'll show you, I'd like you to show them what it's like to die. This is him in our unit with a beer in one hand and his little dog in the other. He came in our unit for pain control. He went home. He went on a cruise to Vanuatu, and he did some fishing as well, and died with us. But he had very severe pain, and that was a big challenge for us to manage. And this is just taken from the whiteboard in a hospital, in the Royal Hobart Hospital, where I was consulting in, we have a big consult service in our hospital. I imagine you do have one of those at the John Hunter, but maybe not. No, that's difficult. So we go and see, that's one of the busiest parts of our service. 60% of all of our referrals come from the Royal. But this is just with, again, permission of an elderly Dutch lady who had a lymphoma. This was her and her family basically telling us who they were, and also telling us who everybody else was that was involved in the case. And you'll see that my card, the palliative care consultant's card, is tucked down in the corner. So the other thing about the end of life, she died a few days after this with intestinal bleeding. It is a complex system as well, with lots of players involved. So the question was, the essay that was set was how we die. That really falls down into when, how, where, why, and I've just put sort of euphemistically there, whether. And this is an issue of public concern. It's interesting to see that the Economist Intelligence Unit and Demos, these major think tanks that normally do big picture political and economic stuff, have actually been looking at the end of life over the last few years, have been commissioned to do this work. And here in Australia, the Grattan Institute in Melbourne will be bringing out a report shortly and is running another major seminar day to look at the end of life. And in fact, I'm grateful to Hal Sverrisson of that institute for some of the slides I'm going to show you today. So one of the problems of coming second in the order is I failed to sort of compute how some of what I was going to say would already be said by Peter. So where he's already said it, I'll just sort of race by. But as he said, we are ageing, and the interesting thing is not on the slide here. 1901, and this is something I say to the medical students. I actually ask them a question. I say, in England and Wales, what do you think was the significant demographic change that happened in 1901? Well, obviously nobody will know. So let's put it another way. So, well, what year do you think was the first year in which more old people died than babies? And they'll say something like 1977, which is when I graduated from medical school. And in fact, the answer is 1901. So can we imagine, that's within the life of many of our grandparents, can we imagine a time when more babies died than old people? So the other thing that's happened, and this is one of Hal's slides, is that mortality is now being compressed. So the good news, we heard a lot of bad news before, but one of the good bit of news is that in Australia, well, our chance of dying throughout most of life is actually very low. But it certainly starts to take off once you pass 60. But even that's quite good, but it's very steep then once you hit your late 70s. And most Australians are going to die between 75 and 85. This compression of mortality will actually lead to an increase in the absolute numbers of deaths over the next few years as this pent-up dying, if you like, starts to happen. All the dying we've saved up. My removal man down to Hobart said, "Are you an undertaker?" I said, "No, why did you think that?" There were all these cartons of books. He said, "Because every second book's about death." The other thing he said is that we move 10 people up to Queensland every year, we bring 8 of them back. So if you want to go back to Melbourne, don't worry, we understand it. This is the age composition in our service. So as you can see, I'm going to try and use the pointer here, but probably quite unsuccessfully. I might just talk to it. As you can see there, we're now seeing 22% of our female patients are over 85. Now this is new for us. This is a very big change in the composition of our patient referral base. And we're seeing people throughout the life cycle, but mainly in there from the 50s onwards. So how are we dying? And I will go through this quickly because it's already been said. Busy slide, don't try and look at it. You can look at it up on the ABS website. But what it's basically showing you is that ischemic heart disease is going down, stroke is going down, all cancers are going up apart from colorectal. And I'm thinking that might well be a screening and better treatment result. But for most of the cancers, the death rate from them is going up even where treatment is improving. But the big winners, this 140% roughly increase in the amount of death certifications due to dementia. So we really need to be helping our communities to understand that dementia isn't just a bit of bad luck and a bit of memory loss, it's actually an inexorable, fatal condition. And the other thing too is this slide just shows multiple death causation, and the key figure is that 3.2 over there. In Australia, your death certificate now on average will have 3.2 causes of death entered upon it. So what's happening now is you're not dying of one disease, you're dying of about 5, and you're dying at a much on average, much later than ever before in human history. Now, this is a complicated slide from the Grattan, and I put it in only to show you that sort of pale, that yellow bump there, peaking in the 60s, is a measure of morbidity. So we may be living longer, but we're actually carrying a greater burden of disease and disability. So when Johnny Howard said there, we all need to work till 70, what you have to remember is between 60 and 70, stuff starts to happen. I won't labour this, but this was Joanne Lynn's contribution, these 3 models of dying, which I think have actually been very helpful in describing the way we interact with death in the health system. And as you heard, the frail, that last dwindling thing is the new happening mode of pathway to death. And I would put it to you that this is the scenario we're in. Living longer, taking longer to die if we recognised it, up to 2 years at the end of life with physical deterioration and disability, increasing symptom burden and increasing dependence on others, which of course we don't like. Cognitive disturbance is now common, and some predictions say up to 1/3 of the Australian public will eventually have some form of dementing process going on. And the problem with that, of course, is lack of capacity and the tendency for people to get more aggressive treatment when they lack capacity. So we'll hear a lot more about that with advanced care planning over the next couple of days. And more decision points, because there are very few what I would call zero options. There are very few situations in which you can make an argument of absolute technical futility, i.e. there's no chance of this treatment conferring any benefit whatsoever. Full stop, yours sincerely, the doctor. You can tell I say it quite often. And the other thing to say is that our level of function as we get older clearly changes with the morbidity. And you can see here this rather busy slide will just show you that if you look at our inpatient units on the left in Hobart, these are Peacock data, by the way, the University of Wollongong, Kathy Eager and her group have set up this palliative care outcomes collaboration. And so we collect these data. And you can see there that a large proportion of patients are skewed towards the more the lower level of functions, and at the top there in our inpatient unit 10% of patients are actually unconscious, whereas of course in ambulatory care at home it's much lower. But you can see there's a very big burden of poor function in a palliative care population, as you would expect, and a high symptom burden. And most of the studies come out roughly the same. Pain's right up there, anorexia, constipation very common, but weakness. And the key issue in all of this, these what I call the intrinsic constitutional symptoms of dying, which are very allied to frailty, are the real indicators of how people are going to do, not the serum rhubarb. And this is a nice study from Irene Higginson in London, basically showing that pain, breathlessness and fatigue are the final common pathway symptomatic components of most disease processes. So whether you've got cancer or heart failure, it's those constitutional symptoms and that aching all over type of pain that will most commonly confront patients and those who look after them. And sorry, this is a terribly busy abstract from a piece of work that Peter Hudson did at the Centre for Palliative Care in Melbourne when I was there, just looking at reasons for requests to die. And this really echoes what was said last night, that buried in there, and I'll just speak it out so you don't have to look at it, is that when you look at the evidence for requests for assistance to die, it's not this kind of archetypal patient rolling around in pain. It's actually around issues of existential distress, loss of independence, and loss of function. And we have to recognise, and those are things which we don't actually have treatment for, and they're connected deeply with personhood, where medicine and health has a very limited capacity and frankly has to be very careful about how it engages, lest it becomes the story itself. And this is just a study of symptom prevalence that we never published from one of my residents in Adelaide nearly 20 years, over 20 years ago now, Evelyn Catt, and she just took all of the symptoms that have been described in the literature, put them on cards and showed them to patients and asked them whether they'd had the symptom over the last 48 hours. And you see the number of symptoms in this sick inpatient population was 17. So they had lots of things going on. But in terms of distress, there were only 4 or 5 that tended to be picked out. And this is a busy slide again, but it just once again shows you lack of energy is right up there in terms of commonness. And then when you look at the distress score, so what bothered you most, pain comes out on top, vomiting, and again, lack of energy. And in anthroposophical medicine, which is something I've been exploring because our children are in a Steiner school recently, they talk a lot about how you've still got the will, but you haven't actually got the life force anymore. And I think these are, and I've found myself talking to patients about it. It really resonates. They say, yes, that's exactly what I feel like. So you still want to go on the journey. You've still got the car, but you haven't got the petrol to put in the tank. This is again on symptom burden. These are real data from our unit. Again, a busy slide. I probably should have dropped it out. But just to say we are researching these things now and trying to measure our performance in addressing them. And this is just showing the spread of symptoms in the stable and unstable peacock categories in our unit over the last year. And once again, you'll see there, the interesting thing is breathing problems. And if you're dyspneic at rest, that's a very, very poor prognostic factor. If you have one episode of delirium, that's a very poor prognostic factor because it indicates lack of reserve. And some attempt to actually measure how we're doing with symptoms here. A long way to go on this, but on the left, it shows that if you've got no pain, then the chance of having no pain at the end of episode of care in our service is very good. I would hope so. If we were manufacturing, it would be a problem. But on the right, you can see if you've got moderate to severe pain, in these episodes, we're actually only getting down to no pain or mild pain in 50% of cases. Now, I want you to take that with a pinch of salt because I'm not sure quite what this reflects, but it does show you we're making an effort to try and see how we're doing. These are the components of our service. We address pain control, symptoms, communication, family support, ethics and decision-making at the end of life. We do quite often get invited to the type of conferences that Peter's having in the ICU. Not always, and it's not always necessary, but we do come if we're invited. Grief and bereavement work. We do a lot of multidisciplinary teamwork. And one of the things is that we need to have time for this work. We also need expertise, and we also need to recognise that it's relational work. This is just a slide, again, another busy slide, but I'll just speak to it and say there have been 2 studies that actually show if you're referred to a palliative care service for supportive care, you might even live a bit longer. Now, that's not why I've been doing this for the last 20 plus years, to confer a little bit of additional life, but it's really interesting, this idea that if you adopt a palliative care approach, all is lost. Well, in fact, not for these lung cancer patients, they actually did better, and when they died, the families did better as well. And this is obviously how we try and engage direct care, shared care, consultation, and training and support. So we have to work across a broad front. 147,000 deaths in Australia in 2012, 30,000 patients accessing specialist palliative care in that year, and a 12% increase from 2010 to 2011. In Tasmania, we have 4,000 deaths a year, and we know we see just under 50% of them. Now, I've put this slide in since last night because when I'm talking about palliative care, I think it's important for you to understand that we work according to what I call the Ontario Coroner's Principles. These are the principles of how we use drugs, particularly in palliative care. That the care is intended to solely relieve suffering, it must be administered in response to suffering, it must be commensurate with suffering, it cannot be a deliberate infliction of death, documentation is required, and the doses must increase progressively. There are some causation fallacies, and we heard it last night, the furphy, if you like, of the big opioid dose. When palliative care is practiced according to acceptable international standards, opioid dose escalation for pain and symptom control, sedation in the setting of end-stage agitation or distress, so-called terminal restlessness, do not cause death. They may make a contribution in a multimodal causation model, which is impossible to unravel, I concede that. But we don't, on our community programs, walk around fearing that the next dose of opioid breakthrough is going to kill the patient, because it isn't like that, and you need to know that, those of you who are not in the field. Nor is it appropriate to view treatment abatement, that is the cessation of treatments that are not working anymore, as causing death. That's not true either. The cause of death is surely the underlying condition in any jurisprudence, philosophical or medical understanding. And in the last few hours or days of life, hydration and nutrition are not routinely used in our unit, and their absence is not a cause of death. And we have to do a lot of work with families to work that through too. So terminal sedation is very widely used. Nearly everybody in our unit will have some type of terminal sedation, and sometimes I do wonder about that. And in fact, we're hosting a small meeting in Hobart on the 25th of October, I think it is, where some anthroposophical nurses and doctors are going to be talking about how they try to manage death without such a heavy reliance on drugs. And I'm very interested to see what they do, because I do wonder sometimes why we're having to use such cocktails. So we do use sedatives, normally benzodiazepines, antipsychotics, and occasionally barbiturates to maintain comfort and dignity during the dying process. The key issue here, and this is the problem for the law and ethics, in clinical medicine, we can't do this work unless we acknowledge a terminal phase, unless we diagnose dying. And it's very hard to put that into law or regulation, because at the end of the day, it's a clinical diagnosis, and there is an element of subjectivity, and we don't always get it right. But that's the nature of clinical medicine. So the drug doses in this situation are titrated to induce relaxation. This often results in sleep or a state of deep, continuous unconsciousness until death. The use of sedation is also described as a last resort to manage pain and for the relief of other refractory symptoms such as delirium, agitation, or shortness of breath, for the palliative care of patients who are not imminently dying. This practice is far less common and is far more controversial and has sometimes been referred to as pharmacological oblivion. But most terminal sedation is for people who are dying, and it is in order to manage behaviour and distress that we assume is distressing to the patient, although we don't know. Certainly, people tell us that's not the way they want to die, and certainly for the onlookers, it's a major issue. Where do we die? Public policy in Australia is very driven by this. I don't say it's unimportant. Obviously, place of death, if it's important to you, it's important. But I think it is overrated as a public policy imperative. What we see is that if you look at our southern Tasmanian figures there for place of death, because we've got a home care service, 30% of people die at home, still 40% in the hospital, just under 10% in a nursing home, and 22% in our 10-bed palliative care unit, because we've got one, and that's how it happens. If you look at the national figures overall, it's 16% at home, 54% in hospital, 10% in nursing home, and 20% in palliative care units. And in the United Kingdom, interestingly, where there's a large independent hospice sector and 50 years of history of doing this work, 18% at home, 58% in hospital, 17% in nursing homes, and only 4% in palliative care units. And here are the global figures. This is the Grattan Institute again, showing that we're a little bit midway through the league table of place of death, all the way from Japan with very high levels to New Zealand with some of the lowest national all-comers figures in the world. What we do at our service is we follow the patient where they need to be, and sometimes that's the hospital until quite late in the disease process. You know, for instance, with haematology, you're still having those top-up transfusions until we make the decision with you that it's now time to stop. Usually when you're getting down to 1 to 2 weeks of transfusion time. Obviously at home, and trying to help people to be at home as much as possible. And I think rather than place of death, I think perhaps a more interesting and difficult question is what percentage of your last few months of life did you spend in the place you wanted to be? And obviously a specialist inpatient unit if you've got it. The why or even whether. Well, one of the reasons I show Bishop Fox is because I would say that preparation for death is in some ways seen as problematic in our culture due to changes in religious adherence and worldview. That interestingly, we're quite comfortable to say that it takes about 18 years to come to adulthood. That's well understood. Probably in the case of men, 35 would be a more realistic figure, or never. But there is no space for aging as decline and a process of dying. So ageing's okay if you're doing healthy aging, and apparently you've got to love bingo and community singing, both things I hate, so it won't fit in at all well there. We actually did have a patient who went out, we thought was in the terminal phase, perked up a little bit, went out and spent all night at our casino in a karaoke thing. Now, for me, that would be an idea of hell, but for her, it was wonderful. Joanne Nin, I think, has rightly painted the picture that we have to look at the last 2 years of life, but we don't know when they're going to be, do we? It's something where you have to recognise the realities of the situation, and that's one of the big challenges. And it is primarily about comfort and dignity. I mean, dignity can be a problematical term. I think it's an interesting term, but we kind of know what we mean. But there are also ecological and economic dimensions which are unavoidable. Catherine May is an interesting American author who lives in London who wrote this book called Amortality. He said the problem is not immortality, that we think we're going to live forever. It's just that amortality, we've kind of written out of the script. Buy the book and do the quiz at the end and see how you score. And it sort of says that, you know, idiots like me who have just reached 60 shouldn't be playing 5th grade hockey. It's really stupid. I look at my grandfather, pictures at the same age, and he sat down and smoked his pipe and did the garden and drank a gin and tonic in the evening. Probably fewer than me, but anyway. This idea that none of us are acting our ages. And it's a nice take on it. This is a much more sobering thing, and I have to say that in my amateur philosophical readings, I found a lot in existentialism, and particularly in the work of Camus and Sartre. And I very much liked Michael Ignatieff, this wonderful Canadian writer and former leader of the opposition there. He did a biography of Isaiah Berlin, who taught him philosophy at Oxford University. Berlin, as a Russian Jew, was fortunate enough to be in Britain and in America during the war, but these were his reflections on the Holocaust. He says, and about the transportation of Jewish people who didn't know. There were rumours they were being resettled. There were rumours there were death camps, but a lot of them went thinking they were being resettled. And he says, why does this deception, which may in fact have diminished the anguish of the victims, arouse a really unutterable kind of horror in us? Surely because we cannot bear the thought of human beings denied their last rights, of knowing the truth, of acting with at least the freedom of the condemned, of being able to face their destruction with fear or courage, according to their temperaments, but at least as human beings, armed with the power of choice. We hear a lot about choice in healthcare, but this is, I think, Sartrean mauvaise foi, bad faith. You know, if you don't take responsibility for yourself, then you can't expect other people to. Very challenging. 5 minutes, thank you. There are notions of the good death. I agree the problem is, the term can be a problem. But when you start to talk to people, as in this very nice qualitative study by Steinhauser, you'll see that the things emerge that we probably might expect. As people do want to be comfortable, they do want clarity of decision making. They do actually do preparation for death if they're supported to do so. Not everybody, but there's a very strong thread of that. Completion of life, affirmation of the whole person, and still being able to be useful. Doctors emphasise the biomedical aspects, and so they should. That's their job. But the importance is that the biomedical doesn't dwarf the biographical, the spiritual, the other dimensions of human existence. And this is a study we did on enduring guardianship forms in Tasmania, which shows that 47% of people who lodged one had something to say about death and palliative care. So people are thinking about these things. But it's a broad spectrum, all the way from keep us alive at all costs, let us die, and help us die. And as we've already heard, this is a deep fault line in our societies, and we're not going to resolve it. There are three attitudinal barriers, in my view. One is don't talk about death, it will kill him. The other is that you can never give up on a patient. And the other is still that the use of opioids and sedatives contribute to death, the cause of death. But the barriers themselves, in my view, are not primarily medical. That's the key. They arise from social, ethical, religious, and political considerations of death and dying, and they're deeply embedded in history, culture, and politics, so they don't change quickly. I think Alan Kelleher was quite right when he said, you clinicians who do the work and think that you're going to change the world by doing clinical work, you won't. As Peter was saying, you have to engage with the polity in its broadest sense and with the population and the community. And that's what Alan tried to do in his somewhat oxymoronic sounding concept of health promoting palliative care. And so we've got this healthy dying initiative in Tasmania, which very much echoes those thoughts of Alan's about dying being recognised, acknowledged and supported, and making sure that decision-making is orientated towards timely and appropriate provision of palliative care for those who need it. And there are three elements. There's the goals of care form, which in our hospitals replaced NFR forms, promotion of advanced directives, and various health-promoting activities. And that's the goals of care form. The key thing there is that we ask clinicians to work out, as a result of meticulous assessment, are you trying to cure the person, in which case there's no limitations, it's all on, unless the patient has a specific treatment they don't wish to have, like a blood transfusion if you're a Jehovah's Witness, palliative care, which could go on for months or even years, and terminal care, which is imminent death, i.e. we think you're going to die this week. And that distinction between the palliative and terminal category for us, operationally at the bedside, is absolutely critical. There is a world of difference of what we do for people who have perhaps a year to live with bony breast cancer compared to somebody who's going to die tomorrow. And you can diagnose dying. I've never actually validated this, but these are the sorts of things that we go through at the bedside. Any one of them on its own would not necessarily be indicative of dying, but put them together and a picture quickly emerges. And it's actually the constitutional symptoms that are the most predictive in all the literature. And we can talk about these things. We can find out, first of all, what people make of it. So many times I've asked somebody, something like, how do you see the future? And the patient will say, well, there isn't one for me anymore. What are your hopes and fears? We have to recognise that in the medical encounter, people are in fight and flight. They are frightened, often of us, of the environment. I'm even frightened going into my own hospital sometimes, It's not surprising, but then... so we have to recognise this. And people are non-linear. I told them yesterday. Yes, you told them yesterday, but they're not in that space. This is the oscillation work, the dual process model in grief. That for after death, but I see it in life all the time. People slip around from resignation and acceptance to hope. And as Michael Carroll says, the Irish psychotherapist, that what patients cannot tell us, they will make us feel. So the issues, as I would see it, that are before us, that come into the public and the academic domain are causation. I think that is very important, probably overrated, but it is certainly there, and the big issue there, obviously, of euthanasia and physician-assisted suicide. The residential dimensions, where are you when you die, home versus hospital. The physical, our preoccupation with the body, very understandable, but of course it mustn't dwarf the spiritual, the existential, the postmodern, the multicultural world that we live in. And my time is up. I will just say, though, that I think in all of this work and all these deliberations, we need to work with our mind, our body, and our spirit, whatever we conceive that to be. This is our little Steiner school near Hobart, where the principal talks of working with your head, your hands, and your heart, and actually ask the teachers every day, are you teaching from the heart? And as Daniel Callahan said, medicine can give us a longer life and a slower death. It can also keep us alive when we might be better off dead. Thank you.
I have a question.
My name is David McIntosh from New South Wales. I'm a palliative medicine specialist, and I would like to ask you about the interface between acute medicine and palliative care. I work in a service where we are very aware about what happens to our patients who have a palliative care label, who may not be imminently dying, but who present to emergency department with an acute medical emergency. And one of our criteria for admitting people to the service is that we ask what will happen to this person if they present to ED with a non-dying cause-related medical emergency. Does that make sense?
Yeah. Is this mic now working? Yeah. If I could lead off in answering that, I think the whole project of specialist palliative care is at risk of failure. I went to a palliative care conference and I said that. I said, your whole project is at risk of failure. And the reason why is you've become a specialty and therefore bound by the rules of specialisation. And that wasn't, I don't think, the intent, but palliative care, certainly the hospice movement, was a critique of medicine in a very radical way, but it fell into the trap of becoming a specialty. And therefore, it opened up the opportunity for people to say, that's the specialist palliative care job, not my job. And although Michael finds it hard to believe, I work on a 1,000-bed campus with no specialist palliative care service. So I never encounter specialist palliative care people except at conferences. But I think that the scenario you're talking about is exactly where specialist palliative care runs its greatest risk of failure, which is that there is where the opportunity is to recognise that somebody might be dying, and where does the expertise then come from at managing that situation if that's what we decide. Because the risk is that we'll just abandon that person rather than converting their treatment from aggressive medical management through to active palliative management. And I think that that's where the risk of failure is greatest. Yeah, you've got to come back to that.
Well, actually, what we are worried about is the reverse. Somebody, say a woman with breast cancer and a couple of bony metastases linked to the palliative care service for pain control who presents to ED. And they're seen because ED sees palliative care as being terminal care, and that they're abandoned in the other direction. Instead of being offered acute care, they're treated palliatively.
Yeah, and exactly the same issue that I would come back with, which is that's the issue with the specialisation. You're under the palliative care team. You're under. I love that expression. You're under the doctor. You're under this particular team, and therefore no other team feels like they have the authority to deal with you. I think it's the mistake that we've made with geriatrics represents the alternative view, which is, of course, everybody's old. We've seen that. So the geriatricians can't look after them all. So what's the specialty of geriatrics to become? And I think the specialty of geriatrics has actually actively tried to evolve into an organisational and teaching role that I look for from specialist palliative care, but in my particular context, I have yet to see.
So Peter, when I'm just seeing Will Cairns there, we were on the original college committee setting up the specialty. We obviously should have come and had a chat with you before we set off on the journey. We could have saved ourselves a lot of grief. But I guess I think one of the problems is that, yes, the need for palliative care and its usefulness has expanded a great deal. And in a way, it's almost been a victim of its own success. And I suspect that in a lot of places it is stretched. But the other side of it is that palliative care was never meant to take over all death. It was never meant to be, everybody had to be under the palliative care service. And so I'd be delighted if you send me your CEO's email. I'll certainly send him an email saying what a wonderful idea it is for a flagship 1,000-bed teaching hospital to have a consult service so that we can be brought in when you think that what we have to offer will value add the experience. And so I would see us as having a much more consultative role. So I don't want to be woken up in the middle of the night, and I don't think it would be helpful for every patient who comes into our ED who's thought to be perhaps in danger of dying. That would not be a good place for our service, and we'd end up involved probably with about a third of the admissions in the institution anyway, and I don't think that would be profitable. But I guess our role is that if and it certainly does happen, I admitted a patient directly from the ambulance ramp the other day from our emergency department. We do have interaction with them. They do ring us up for help and advice, and we obviously offer it. But part of our role also is to support and educate and help the rest of the health community to look after people as they reach the end of life. Because the area under the curve is too big, you're right. for us to be involved with everybody, and I don't even think it's necessary that we are.
Thanks for two great talks. Peter, you're a great speaker and you're always very good at putting out the problem. And
Don't ask me the answers.
And I'm always looking for people's talks, including yours, in terms of where's the solution. And in the end, to find a solution, who needs to take responsibility? Now, I know that the answer is everyone's got to take responsibility, but someone's got to start with taking responsibility. And, I mean, you know that we've been mutually looking at this whole area of end-of-life care for, a decade or more. And it's hard to know who we're going to get to take responsibility first. Do we get the doctors? Because the problem with the doctors is they've got a conflict of interest. In private hospitals, they've got a conflict of interest in making money, doing the cardiac surgery on the 85-year-old, who we all know is not going to survive very long at all. And the conflict of interest in wanting to actually go ahead and do that operation because they haven't done that recently, or making the great diagnosis, or putting the patient through the oncology trial or whatever. So doctors have a conflict of interest. What about the medical administrators? They have a conflict of interest in terms of how they spend money. I mean, we've been running Respecting Patient Choices at Austin for 12 years now. Up till this moment, our hospital has not put a single dollar towards it. All the money has come from external sources. And I've had, Karen and I had a meeting with our CEO only 2 weeks ago saying, when are we, the hospital, going to start putting money towards this? Well, we're struggling to meet our own budget. And you talk about return on investment, you talk about we've got to start putting money into advanced care planning and better end-of-life care now, knowing that you'll see a return on that in the near future. No one's prepared to do that. So, the doctors, medical administrators, what about the politicians? Well, this whole area is fraught with scariness for them in terms of what they perceive society will view on it, or the Catholic Church or others, where there's a lot of, the whole euthanasia debate. And I feel like saying to all of them, because they all say this is really important, I keep saying to them, put your money where your mouth is. We put money towards dementia now, towards cancer, towards diabetes educators, asthma educators. Where's the education of the doctors? Where's the money to do that? We've seen from Ben White's and Lindy's papers that doctors know very little about this whole area. So do we put money towards education, towards advanced care planning, towards palliative care consultative services? So I invite both of you to tell me what's the solution.
Thanks, Bill. You're getting quite a reputation for asking the hard questions. Well, to echo essentially everything you said, when you go to New South Wales Health, the first thing they tell you is there's no money for this, but. So that's almost the opening gambit, that there's no money. We go to the community increasingly, and they're telling us we're looking for leadership from you. And when we ran Respecting Patient Choices at our hospital, 49 out of 50 wanted to talk about end of life. These are the patients. I mean, it wasn't the resistance to talking about end of life didn't definitely, quite clearly not come from them. It comes from us. So, I mean, to reiterate something I've already said, we have to be the agents of that change, seemingly unfunded. Do all those conflicts exist out there? Absolutely they do. I've just resigned as the director of the Newcastle Private Hospital because they have taken on cardiac surgery. They are operating on people for financial reasons. Ethically, I can't bear it, and I'm going. Fee-for-service medicine introduces a skewing into the system, which is you can't do anything about. It's just there. Doctrinal input, particularly in New South Wales, is enormous. It can be hidden in different terms, as to an extent it was last night, but the doctrinal influence on decision-making is clearly there. The only thing I think that I see is there's 300 and odd people here, and I think that if there's going to be any change, it won't come as a result of pressure coming from above downwards, but it will come from the bottom up. And the fantastic work that you've been doing and plugging away at for years without support will bear fruit, but it'll only bear fruit because of a public impression that something needs to be done. And I think we have to go public with how bad things. We've all said how bad things are. We don't talk to the public about that, but at some point we're going to have to.
Bill, I think all of us in palliative care have been addressing these issues, probably in Australia for about nearly 25 years now. And one of the talks I've given throughout my appointment in 4 universities now is false perceptions of the law, what we think the law says, and medical perceptions of what the law requires them to do. But the trouble is, one little lecture from me in a 5-year course, a visit to a hospice unit isn't enough. At UTAS, I'm paid 0.06 of an EFT to do the whole of ethics, all of Theme 4, AMC Theme 4, which will be domains next year. So I can't do a lot with that. And so I think, in a sense, yes, we do it, but we don't reinforce it. It's not sophisticated enough. So I think that at a university level, we would certainly need a better critical mass and faculty of teachers who are actually paid to spend time teaching and researching end of life. We have no centres really, sustained centres of death studies in Australia, for instance. It's very hard to do in Australia or New Zealand. So I certainly think the Academy could put something in as well. But yeah, I agree with you. We need to do more. It's not that we haven't been doing it, but I think we've been doing it off the side of the desk, and we're probably not reinforcing it and modelling enough.
Charlie Cork from Geelong. Can I just take you back to the hospice movement and the beginnings of it with Dame Cicely Saunders, and I'm also old enough to have been lectured by her. I wonder if it's time to, whether we could just reflect on the complete separation of the hospice movement from the hospital movement when it started, and whether it's time to say sorry for that.
Oh, that was for Michael for sure.
Yeah. I was at Bart's and we had a half-day visit to St Christopher's. I didn't go because my cousin from Melbourne was here and he wanted to go to the cricket and have a few beers, so I wagged the whole day, but I'm the only person in the year who became a palliative care specialist, so that's really interesting. Alas for medical education. But I think there's been some really good stuff written about this journey, this remarkable journey, and the founders of palliative care, and about the mainstreaming of it. It's starting as a protest movement, and I agree. I kind of like that stuff. I like the pioneering. I like going out there, and I like being a little bit of a sort of revolutionary. So for me, I felt like it was a bit like that, and that we gradually came back into the system. We became kind of conventional, and some people said normalised in inverted commas. But I think that's just been an inevitable journey of any charismatic kind of social movement, which this was. That's what was always bound to happen. And there's some very good things in it as well. I mean, I think my early days at the Royal Adelaide Hospital, you really did feel as a very unusual, but they'd never had a director of palliative care before. A lot of them didn't know what it was, but they were very suspicious of it. And everything was up at the Mary Potter Hospice. And we pulled that together very consciously. And I think with some good results. But I now think, and I look at what I do, and sometimes I feel like we've become just more of the same. We're a symptom control factory. And so, so I think there are arguments both ways, but the history is the history. The thing now is to take the ethos of what those early pioneers did and keep it alive somehow. It's not easy, but we've got to do it.
Thanks, Ben. Firstly, quickly, Peter, to say that, yes, in all of my research, the community, particularly older members, want to talk about end-of-life issues and death and dying, but they want the doctor or the nurse to raise it. And Michael, I was pretty shocked at the beginning of this year when I found that ethics had been taken out of the nursing curriculum at my university. I just kind of despair sometimes. But my question is about, I get lots of emails and calls from people wanting advice about what they should do with people in their residential aged care or acute care or whatever, who they believe are not getting proper care. And a recent one was a woman whose husband has advanced dementia and pain and other symptoms, was deeply asleep most of the time. His medication seemed to be working well in that respect. But the nurses kept waking him from that deep sleep to feed him. And his feeding was automatic, reflex. They'd put a spoon in his mouth, he'd open it and take whatever it was, but they had to wake him out of his deep sleep. He had an advance directive which said he wanted comfort care only. So I contacted Lindy and Ben and Mal, who are part of the research team I work in, and said, what do you reckon? And the nurses said they had to do it because it was their duty of care. Well, we came to an agreement that their duty of care was to respect his advance directive, which said for comfort care, and to wake him from a deep sleep was not respecting that. And I'm just wondering, in terms, if it had been artificial nutrition hydration, that would have been simple. His wife could have requested the feeding tube to be withdrawn. This was normal provision of food and fluid. Well, normal, except you have to wake someone from a deep sleep in order to provide it. So I'm just wondering if either or both of you could comment on what nurses in that situation should be doing, or how we change things.
Yeah, well, quite. I do think that the nurses are caught in a lot of moral distress at end of life. I think that that's not just in residential aged care, but I see it in intensive care and almost throughout the hospital, that when we get into this very difficult situation, that it's the nurses who bear most of the distress that results from that in terms of healthcare providers, no doubt the patient and the family also. So I'm very sympathetic to nurses and how we provide guidance for them in that circumstance. I wish I had the option of ringing Ben and Lindy every time I had a problem. That sounds fantastic option. But I guess one of the things that wasn't on my list of speed humps for ethics was duty of care. But I think we perhaps should put that on the list as well, because I think that term is very interesting, and we do a lot of things under the general umbrella of duty of care. And as soon as we try to drill down and ask, what exactly is the duty of care, and how are we establishing that, and what's the standard of that duty, nobody can give you a straight answer. And in that context of ordinary versus extraordinary ways to feed somebody, that's exactly where you're going to run out of steam with this notion of duty of care, and run into all the other issues about doctrinal issues and stuff like that, and Pope John Paul II, whom we don't try to talk about too much in End of Life. But I do think that we should revisit the question of duty of care in the context of end of life, and I'd be very interested in what Ben and Lindy said to you.
Yeah, I think wheeling out Ben or Lindy with a wig, and saying, look, this is actually what the law has to say, be quite helpful in a way. And John Paul II's death was interesting. There's a wonderful article about it in Mortality by a Catholic doctor in Glasgow. A wonderful article about that whole.
He wasn't artificially fed at the time.
No. But look, with regard to the scenario you've painted, which happily I don't meet too often, but anxiety about nutrition, yes, it's well out there in all areas of society. I guess the first thing to say is, what is a kind of normal dying like? What's dying like? And one of the key things that I say to people is, remember the worst flu you've ever had in your life, and your mother was trying to feed you, and you didn't want to eat. That's what it might be like for X now. They're beyond appetite. The life force is going. The will is now going as well. And it's over. And part of the closing down, it's like, Strauss's 4 last songs, Das Abschied von der Erde, all of this going stuff. It's about leaving. And then a Latvian person told me there's a proverb there that says, instead of saying kick the bucket in Latvia, you say put down the spoon. So I think that it's a cultural narrative about what dying is actually like. In law, though, I think there was one of Margot Somerville's colleagues had an interesting take on this. He called it normative causation. He said we need to get back to the notion that there's an underlying cause of death and a chain of causation, and the absence of the food and drink doesn't disturb that chain of causation. So in terms of causal anxiety, which I would posit is a major issue for health professionals, often as a result of false perceptions about what the law says and requires, particularly in this very bandied around term duty of care, which must drive you guys mad because it's bandied around to defend all kinds of really silly practices that the person actually doesn't really want to do either, but they feel somehow there's an impost upon them. They don't know where it came from, they can't reference it, but they believe it to be present. So I think that's what we've got to deconstruct.
Question from Rodney.
Rodney Simon from Melbourne. Before I make my question, I might just comment on Colleen's, and that is to say what is happening in the instance that she's told us about is what I would call an interference with natural dying. Now the question is to Michael. Michael, I think you were indicating that palliative sedation and the use of sedatives and analgesics does not hasten death. In my experience, not nearly as vast as yours, but I think there are patients, for example, who have very, very, very severe pain, neuropathic pain, for example, who may not be actually near death, but their symptoms really demand, and they would possibly be demanding, that they be given intense sedation and pain relief that essentially is an anaesthetic process to relieve their pain. And the other group are those who have intense terminal fatigue, which is incredibly distressing. But they too may not be dying for some weeks. And in that case too, I think there may be a very real necessity for providing them with medication. And I think in both of those cases, the sedation and the pain relief, while it's not the intention to hasten death, does actually in fact do so.
Thank you, Rodney. As you know, I am a supporter of voluntary euthanasia and physician-assisted suicide. I'm one of a small but growing number of palliative care physicians who's come to the conclusion that the sky will not fall in if we allow these things to happen, and I think they will eventually. But I do actually also have a responsibility as a palliative care physician to ensure that if the split's roughly 80-20 in public opinion in Australia, very roughly, that we actually have to be able to minister to the 20% as well. And it's very important that we're clear about our intention and our scope of practice in the care of dying people, and therefore I do attempt to make a bright line between the two. I would accept, though, that if you were taking a person who more or less walks into the unit with terrible pain and you say, well, we've tried everything and now I'm going to give you some phenobarbital, then yes, I would say that the, in causal, factual, forensic terms, I'd have a hard time in saying that's not the same as giving you a lethal injection, because in a way I kind of am, slowly. So I accept that. But in my practice and in our unit, as I said, we do a lot of sedation, sometimes I think an alarming amount, particularly when people become benzodiazepine resistant, so we do have to use phenobarbital for people who are very distressed. All of those people are in the dying phase. They're in the last few days or hours of life, all of them. So it would be highly unusual for me to take a person who wasn't dying and sedate them to the point where causation would be truly invoked. What causal contribution drugs make to the timing of an otherwise foreseen and anticipated death and established dying process, I think, is a point that I don't actually think we can empirically test out, that I don't think most people think is actually very important, but I agree it's a potential area for a factual difference between those who advocate legalisation of euthanasia and those who defend existing practice, and a bright line between the two.
Thank you, Peter Singer. I wanted to comment first on the case of the duty of care and the feeding by mouth. I think this is really a legacy of the distinction between ordinary and extraordinary means, because on that view it was held that a medical intervention, as you mentioned, for example, if it was artificial feeding, wouldn't have been a problem because that would have been seen as extraordinary means of life support, but feeding by mouth was seen as ordinary. I think we should reject that distinction as a whole. In fact, the Catholic Church itself, its theologians now often prefer to talk about proportionate or disproportionate, which I think is getting closer to what we ought to consider. And then you can take into account as to what's proportionate the quality of life of the person, and the fact that they're deeply asleep except when they're being woken up to be fed suggests that there's no proportionate gain for the disproportionate inconvenience of waking that person up. So I think we really ought to get rid of that distinction. But the reason I originally stood up was I want to thank you both for very interesting and informative talks. But the question that Michael raised about causation, I think ought to be clarified. I think you said something like, if I get it right, that you have difficulty explaining to the families that you're not causing death by withdrawing treatment, for example. And I think you have difficulty because, in fact, you are causing death, at least on one reasonable interpretation of what's going on, because the time at which death occurs obviously matters. If the person could live longer, then you're causing the fact that they die on Tuesday rather than the fact that they die on Friday or perhaps 2 weeks later, and that is causing death. And you can think about that if you think about for someone for whom it was important that they live to Friday. Suppose they said, for example, my granddaughter's getting married on Friday, I still want to be around when my granddaughter is married, even if I can't be there. And if you then withdrew the treatment on Tuesday, I think everybody would agree that you had caused her death and frustrated her wish to be around when her grandchild was married. So I think what's really important here is that we have a set of, you mentioned then in response to a question, normative causation. I think it is normative expectations of what you will do for people in certain circumstances. And it's the departure from those expectations that leads to people picking this as the cause, whereas in fact there's a lot of different causes going on. So I don't think it's the case that withdrawing treatment is the only cause of death, of course. There's background circumstances that make you decide to do that. But I don't think you should deny that it is a cause of the death occurring at that particular time. You should accept that, but say, well, in the situation, this is a perfectly reasonable thing to do.
Nearly all the treatment we stop in the palliative care frame is treatment that's not working. It's demonstrably no longer conferring benefit. However, there are situations, and I suspect perhaps Peter should answer this, in terms where there is life support treatment, where that's stopped, and where obviously that does influence the timing of death.
And indeed, I would like to say something about that, because we tried recently to get a paper published where a patient had a pacemaker upon which their life depended, and we were requested to turn it off, knowing that on the press of that button, that patient would die. And the question of causation or foresee, because in criminal law you don't even have to prove causation, I don't think. You'll put me right on this, but I think just foreseeing that somebody would die as a result of what you do would be sufficient. But we in the end found somebody prepared to press that button. It was a woman who was very desperately unwell in all sorts of other ways, and her daughter was the one who was saying, I want you to stop this, and if you press that button and stop her pacemaker, she will die. But all of us were very nervous about the causation argument that, is this a withdrawal of treatment, or is this us actively killing this woman? I presented this at the Bioethics Association meeting, and Julian Savulescu was there and said, well, you're clearly killing her. There's no question about that. And when we tried to get the case published, 6 different journals refused to publish it, not because they thought it was academically unworthy, but they were too nervous about how we might be exposed to legal redress for having actually done it. So I'm not answering your question, but I think what you're putting your finger on clearly is not just philosophically important, but practically important in the absolute everyday work that we now do. There's a new pacemaker goes in somebody every 15 minutes in Australia, and other implantable devices that sustain life are also going in, and there's never any discussion at that point as to under what circumstances those things might be turned off again. So there's no advanced planning around that. So we're left with the causative issue of, are we then going to turn these things off and kill people at the end of their lives?
And the reason our renal team so much want to speak to us is the renal dialysis rates for frail elderly people are going through the roof, and over half of deaths in the Australian registry now are due to treatment cessation. Now there is an umbilical cord. It isn't instant, but stopping dialysis is obviously part of a chain of causation. I think a plea to all of you academic lawyers in the room, when I started to study this for my MD, it was Margaret Somerville who put me right. She said, don't think as a doctor that you understand causation from a lawyer's point of view. We spend at least a term at McGill with our law students on causation, and it's interesting that philosophy, law and medicine all actually do see causation from a methodological point of view in a different way. And so we just had to be, I think it'd be good to explore that in the meeting. We did actually have a whole meeting on it that Denisa Mendelsohn put together a few years ago. Maybe we need to have another one, because I think it's a pretty key issue. Causation, of course, being forensic plus determination of legal responsibility. And for us to understand that in medicine is actually quite difficult, because we're very forensic, you know, the hammer through the head and the spurt of blood. But I think causal anxiety is a key issue. Absolutely.
I love the term causal anxiety.
Causal anxiety.
Did you invent that?
I did, yeah. Well,
fabulous. If you don't mind, I'll be borrowing that.
No, that's a pleasure. You get Ashby's causal.
Let me just say in conclusion, I hope you'll keep trying to get that paper published, because I think that issue certainly should be discussed.
Absolutely.
We have now reached time. I might take one more question. I'm very sorry to the folks who have lined up, but maybe you could grab Peter or Michael. I'll just get in trouble from the organising committee for running late.
You are the organiser.
Very
You're in trouble with yourself.
Very cross with myself. Very disappointed.
That's the law for you. They even fear themselves.
Tremendous.
Sorry,
the lawyer jokes have started already.
My name is Joanne Dorr and I'm a palliative care consultant. Thank you so much. Interesting talks. I used to think that if every healthcare worker did 6 months of palliative care at the beginning of their training, over 20 years we would have a radically different healthcare service. But who's got 20 years to wait? As you're talking, I'm wondering if any of us are working in healthcare, we have to have mandatory training and we have to fill in our own advanced healthcare directive, we have to appoint our own enduring guardian, and you cannot be employed unless those things are in place, a bit like vaccinations. But it needs to be the healthcare workers, but actually the administrators and the managers really need to do this as well. I'm just wondering whether you think that would make a difference.
Yes, I mean, one of my dot points that I would have liked to spend more time on is lack of imagination. And what I mean by that is all of what Michael's just portrayed about dying, we don't seriously take is going to happen to us. I mean, seriously, do you all believe that all of that stuff that Michael just said is actually going to happen to you? Seriously? Do you live your lives as if that were the case?
Yes, well, that's the Sartrean comment there, you know, the Michael Ignatieff thing, you know, about taking responsibility for that. But just as an anecdote, at Monash, our students would do a week of ICU, they'd come and do a week of palliative care, and they went back to ICU. Don't ask me why, it was just a quirk of the timetable. And one of the students came back after the ICU block to us and said, I've just spent a week in ICU and a week in the palliative care unit, and I can't tell the difference between the patients. But the interesting thing is, nor can the director of the ICU.
I think that's true, but to be specific, we're redesigning our medical course and we have this domain 4 business happening as well. And the thing that I think might be the best investment for the medical students would actually be none of the things you've suggested, but mindfulness training. And it's the best evidence-based intervention we know of to try and get people to have a little bit more imagination about how patients are experiencing what's happening to them. And it may turn out to be our best investment.
And when I talk about this stuff, I'm always conscious of the fact that it's so easy to talk about other people's deaths. And if anybody knows where this quote comes from, I'm sure I've heard it, that there's no such thing as death, only your death. The abstract concept, leave that alone, you know, that's not going to help you. And Michel de Montaigne, the French essayist, actually talks about this beauty. Don't worry about death, he said. Don't you worry your little head about death. Nature will take care of that for you very nicely.